Thank you all for having me and letting me speak to you all today. I know I met a lot of our pediatric guests yesterday, so looking forward to talking to you today. So that being said, my presentation really focuses on kind of the implementation successfully of the diet throughout the pediatric lifespan. So before I get started, just a little bit about me. I was actually diagnosed with Crohn's disease at about 14. So I have been diagnosed for a little bit over 12 years now. At first, I was started on mesalamine. Even though I was diagnosed with Crohn's disease, they thought that that would be kind of a successful treatment for me. And for a while, it worked. It was really great. I just went about my day-to-day life, took my medication, and didn't really change anything else. My doctors never really introduced diet as a form of management. Initially, it was just kind of, diet doesn't really impact anything. Take your medication, you'll be fine. And for me at 14, I was like, great, cool. I'll take my medicine. This is wonderful. At least I don't have to change anything else. Nobody really needs to know. I just take my medication and I'll be fine. Shortly thereafter, I began having symptoms on the medication. So it was successful for a while. I just kept upping the dose. I don't know if any of you have ever been on Pentasa before, but they're bright blue, gigantic pills, and I was taking 15 of them every day. It was not fun, and it just became a challenge to keep my symptoms under control. So kind of went back to the drawing board with my doctor. I also had a dietitian who was on my team, who they're both now my colleagues, and I went to them and I said, okay, where do we go from here? What do we do? The medication isn't working. How do I solve this problem? And at that point, this was 10 years ago, give or take a little bit now, and at that point, biologics were kind of a new thing in this pediatric world. So there was really only Remicade and Humira offered as my options. Stelara and Entyvio were kind of on the horizon, but not really something that they were recommending for me at that time. So I went back, I took their little pamphlets with, the Humira and the Remicade, and I really gave it a lot of thought. And for me, at 16 years old, thinking about giving myself shots or being on infusions for the next, hopefully 75 years, given that I have a nice long life, was just not something that appealed to me. So my mom and I, she's been such a wonderful advocate for me, she really started digging into, okay, what are our alternatives? Where are our other options? Is it just medication? And we discovered the SCD diet, and we took it to my pediatric GI doctor, and we said, is this something you've ever heard of? Can we try this? And he kind of gave me, okay, well, there's not a lot of concrete research at this point, but I don't think it's necessarily something that we can't try. So he gave me a time frame, and he said, let's see how it goes. Let's try implementing this and see if you're successful. And I clinically improved very rapidly. All of my labs looked much better. My stool studies were improved. Everything was really improving. And so after that point, they became involved with the Nimble Produce study. I don't know if any of you have ever heard about that, but they were one of the kind of forerunners in that study and became really involved with that after I had started the diet. I was so disappointed. I was like, what do you mean I can't be involved? So that was really successful for me. So just seeing that success, seeing what a change I had almost immediately, I decided to kind of pivot career paths and decided that I wanted to go into nutrition to be a dietitian specifically for pediatric IBD patients. So I went to Auburn University for undergrad, majored in dietetics, and then went on to do my dietetic internship at Ohio State University in Columbus, and then started my career at my pediatric GI office as a dietitian and also working in the hospital. So between my outpatient GI office and my inpatient nutrition, there's a lot of kind of continuity of care. So I see a lot of our IBD patients at the time of diagnosis in the hospital and follow them on the outpatient side as well. So that being said, a lot of you probably already know what the benefits are of using SCD in our children, but just to highlight a few points. The traditional Western diet really, really increases the risk for development of those chronic diseases. Like we know, Western diet is high in a lot of processed foods that SCD really eliminates. Improved development of the gut microbiome as well, kind of tying back into Dr. Fasano's talk yesterday, really making sure that we're having a good establishment for the microbiome. And then medication risks. Obviously, a lot of us have been on medications before, and we understand kind of those risks and some of those shortcomings. And then studies have actually shown in some circumstances that medication and diet management can be just as effective as one another. So really tying in those benefits there. So point number one, traditional Western diet definitely increases the risk of development of chronic diseases. So the Western diet, typically high in processed foods, refined sugars, red and processed meat products, saturated fat, corns, potatoes, all kinds of things that SCD eliminates. So with that focus on whole foods and eliminating those processed foods, the refined sugars, a lot of those different starches, it can really help lessen the consequences of that Western style diet. So even if it's not something that we implement 100% of the time in our children, that we didn't start it as soon as they were eating, implementing this early on can be really helpful in lessening some of those impacts from the Western style diet. So moving on to our next point, kind of hand in hand with the risk for chronic diseases, is the improved development of the gut microbiome. So we talked a lot about this yesterday with Dr. Fasano, and like he was saying, the microbiome plays a really crucial role in development of children. So the microbiota found in the human gut really have a lot of important functions, especially for our little ones. So apart from the kind of bacterial communication within the gut, they also help with metabolizing dietary fibers, kind of educating the host immune system, teaching it how to work properly, and also producing a lot of vitamins and minerals that your body wouldn't otherwise be able to synthesize. So really important, especially for our little ones who are moving through trying to cultivate that healthy microbiome from the start. Lots of studies have actually shown, moving on to our next slide, that that microbiome really reaches its peak around 2 to 3 years old, going back kind of to what we were talking about yesterday. But more recent studies have also shown that the microbiome can be impacted as late as your early teen years. So it's always kind of peaking around that 2 to 3 year mark and then gradually declining. But even if we catch it, let's say the 10-year mark, that's a lot earlier than a lot of other people would transition away from that Western style diet. So it's still, even though it has declined slightly in development, you're still catching it at an early enough point that it's really going to make a large impact on the microbiome long term. So even into early teen years, this is really, really crucial. So as we know, lots of medication risks and shortcomings. I'm sure you've all heard the commercials and the long list of side effects on TV, wherever you're getting your commercials. It's really overwhelming to listen to that and to know and to be offered those medications. So the side effects as well as the non-adherence to maintenance medications are two really big hurdles, especially in my personal experience and experiences that I've had with patients. It can be really daunting to hear, increased risk of infections, increased risk of cancers, including lymphoma, all kinds of things that really turn patients off of these medications. So number one, getting them to start the medications and maintain the medications, knowing that those side effects are there. And also, if you're not taking your medication, it's not going to work anyway. So if your child or as a patient, even as an adult, if you're not willing to either go get your infusions, take your injections, it's not going to work. Number 4 is one of my favorite points, is that dietary management has been shown to be just as effective as medication in a lot of circumstances. So this article that's actually up here was partly performed by a lot of my colleagues at GI Care for Kids. So Bailey Koch, Dr. Cohen, Dr. Gold, who spoke a couple of years ago, were really involved with this study. So as you can see over in the figure on the right side, these graphs really show kind of the clinical improvement. So they looked at patients at 12 weeks and 52 weeks who had been on SCD, and they looked at the Harvey-Bradshaw Index, which is essentially kind of puts a number to the severity of Crohn's disease, and then erythrocyte sedimentation rate, so ESR, which you're probably familiar with, and the Lewis capsule endoscopy score. So they did do like the pill cameras and serum albumin, as well as their weight in kilos. So as you can see, there was really successful improvement in a lot of these biomarkers. So it really gave them a clinical presentation and evidence to say this has improved. So as we sort of touched on yesterday, very early onset IBD. This is something that I do see relatively frequently in my clinical practice. And very early onset IBD is IBD that presents earlier than 6 years of age. So anyone who's diagnosed 6 or below would be considered a very early onset IBD patient. It's thought that there's a more complex etiology to very early onset IBD, but that being said, there's been no evidence that SCD is harmful or that it doesn't have the same impact in very early onset IBD. It may be necessary, oftentimes in very early onset, to pair the diet with medical management, being on some sort of medication. In my personal clinical experience, our kids with very early onset do tend to be more severe than some of our older patients that present. So most of my patients with very early onset, even if they are on SCD, do tend to be on a medication as well. So that being said, kind of implementing SCD throughout the life cycle. So ages 1 to 3, kind of that toddler range. I primarily work with children in my practice, especially the little ones. So seeing this successful dietary management across all ages has been really incredible. I find that children tend to be more malleable. They tend to be a little bit easier to work with than adults, especially the young ones. I feel like parents are really, really willing to just say, whatever it takes, we'll throw the kitchen sink at it. I'll do whatever it takes for my child. So I've found that it's been a lot easier to implement the SCD with our little ones. Solid foods are typically introduced around 6 months of age. Usually what we look for with introducing solid foods is if you can sit your baby in the middle of the floor and they don't topple over, that's when they're kind of ready to have those solid foods introduced. Theoretically, SCD can be introduced as early as 6 months of age. The youngest IBD patient that I have worked with was right at 6 months, so just introducing solid foods. So it was definitely a challenge, but we were able to kind of implement SCD on the front end as soon as they were diagnosed and starting to introduce those solid foods. The challenge with these really little ones is that breast milk or infant formula remains their primary source of nutrition. So even though we're introducing those solid foods around 6 months of age, give or take, up until a year to 13 to 14 months of age, typically the bulk of their nutrition is still going to be coming from breast milk or infant formula. So it can be challenging to wean that and start to rely on those SCD foods. Around 1 year of age, we definitely expect children to be transitioning to more of a toddler style diet, having, 3 meals, snacks, all of that throughout the day. That being said, children under 3 have really high energy needs. So as we're transitioning off of that breast milk or formula, traditionally we would transition over to a cow's milk product, so usually whole cow's milk. And in the case of SCD, that wouldn't be something that we would transition over to. So filling that gap can be a little bit of a challenge. But their energy needs are really, really high at this age. So about 80 to 85 calories per kilo, which I know probably means nothing to you, but in terms of adults, usually we say about 20 to 30 at the highest calories per kilo for adults. So definitely much higher in our little ones. So what are the benefits of starting at this age? What are the easy things about starting in this 1 to 3 range? So the biggest thing is caregivers control what is offered. So at this age, children typically don't go to the pantry or the refrigerator by themselves. They're not, opening their string cheese or their Cheetos, whatever it is, by themselves. Usually they have to ask, which is helpful on the part of the caregiver because they can really control that environment. They can control what's going into their child's mouth. They're also typically cared for in a more controlled environment. So most of the time, children at this age are not yet in school, or maybe they're just starting preschool. I do realize that some children start daycare as early as a couple of months of age, but for the most part, even if they are in that daycare or that preschool setting, it tends to be a much more controlled environment with a lower caregiver to child ratio. Outside of that time, even if they are in daycare or preschool, oftentimes they're spending the majority of their time at home outside of those times. So much easier, fewer people involved, the easier it is to control what's going in and out of their mouths. With the early introduction to a wide variety of foods, kind of going back to that microbiome component, the earlier we can introduce all of those fruits, vegetables, all of that to our children, the better in terms of their microbiome development. It can also help eliminate food allergies and set them up to be less picky later in life, which we all want. We want a nice wide variety in the diet. That being said, a diet full of those whole foods, so fruits, vegetables, protein foods, is really going to help set that good kind of baseline for their microbiome. Challenges. So kind of like we talked about a little bit earlier, the transition off of breast milk or formula can be really, really difficult. That being said, it doesn't have to be, okay, they turned a year old, today's their first birthday, we're gonna absolutely come off of this 100%. You can definitely wean off slowly and use that formula or breast milk in a sippy cup to kind of help with that transition. That being said, I know SCD we probably rely mostly on plant-based milks to really meet that need. And with children, it can be really difficult to find a plant-based milk that's going to meet those needs. So things like almond milk are really typically low in calorie, but if you're either making your own almond milk or purchasing in the store one without gums, fillers, looking for something that's about equivalent to cow's milk or as close as you can get. So about 150 calories or as close as you can get. Like I was saying, you're probably not going to get those exact nutrition goals met, but looking for as close as you can to about 150 calories per 8 ounces and about 8 grams of protein. Meeting needs without grains. So grains do tend to be an important component, especially for our little ones. They help meet iron needs with fortified iron cereals. So making up for that can be a little bit difficult. But at the age of 1, they should be able to navigate protein foods, so giving them things like red meats, green leafy vegetables as well. The carbohydrate side from the grains is another important thing to be conscious of. So making up for those carbohydrates with fruits, vegetables, beans, seeds, nuts, lentils, those type of things, just to make sure that they're getting that balanced diet. And with milk as well, making up for those calcium and vitamin D needs is another thing we'll need to be conscious of. Another trick for iron with our little ones is you can use what's called the Lucky Iron Fish. Have any of you ever heard of this before? Okay, I'm seeing a few nods. So this can be a product that you can also use kind of later throughout your IBD journey, especially if you are having some blood loss. It's a little fish. It's actually made of iron, and all you do is drop it into your pot while you're cooking, and it will transfer iron. So something that may not otherwise have iron, and pairing iron with vitamin C really helps with the absorption. So for example, let's say you're making some pasta sauce to put on your spaghetti squash. You otherwise wouldn't have iron, but if you drop that little fish down in there, you've got your vitamin C from the tomato sauce, you've got your iron from the iron fish, so you're getting both of those things together to really help with absorption. Really, the next major challenge is that everything at this age goes in their mouth. From the floor, from the table, wherever it is, directly into their mouth. So really being mindful of what's within their reach is the most important. But let's say they're in school or they're in preschool, the other kids are having animal crackers, they're having Cheerios, whatever it may be, that gets dropped on the floor, or they're reaching over onto their classmate's plate. That can be challenging. So making sure that whenever possible things are out of reach, making sure that everyone's on the same page in terms of who's regularly in their environment. Another challenge, this is for our really little ones, but definitely no honey less than 1 year of age due to concerns for botulism. So it can be challenging, especially with baked goods, but using alternative sweeteners is definitely possible. So tips and tricks, looking for those higher calorie plant-based milks like I was talking about, looking for about 150 calories, 8 grams of fat, and 8 to 9 grams of protein for 8 ounces. The best commercially produced plant-based milk that I've been able to find is Elmhurst, so that's typically what I recommend for my patients if they're not looking to make it at home. Giving them a choice. I know this sounds silly, but with the little ones, giving them inconsequential choices like, do you want blueberries or strawberries? Do you want salmon or do you want tuna? These choices and incorporating them into that process really helps them become involved and be more engaged with their diet. Portion sizes. This is a big one that I run into with my patients. Oftentimes parents are like, oh my gosh, they're not eating anything. I gave them a full plate and they only took 4 bites. That's okay. Keep in mind that portion sizes, and this goes across the board, portion sizes for kids are about the size of their closed fist. So if you hold up your fist, you look at the back, each item on their plate should be about their fist size. So for our really little ones, that's really only about a tablespoon per item on their plate. So if they're only eating 3 to 4 tablespoons, that's plenty for them, but to us, it really looks like very little. Then like we talked about, in place of honey, using those alternative sweeteners like dates, bananas, applesauce, things like that in baked goods to make sure that we're eliminating that honey when needed. Preschool, kind of transitioning out of the house more. They're definitely older and more capable by this age, but they're still really in that instrumental time. So that 3 to 6, we're kind of coming off of the peak of microbiome development, but still very much in that phase. So caregivers still control majority of intake. Their calorie needs are a little bit lower at this point, so down to about 60 to 70 calories per kilo to maintain normalized growth and development. So still high, but not quite as high as our really little ones. At this age, caregivers being able to control what they're putting in their mouth, what's in their environment. They're a little bit more independent in terms of being able to go get things for themselves, 6, much more so than 3. But just being conscious of exactly what's in the home can be really helpful. I find that particularly kind of this age through elementary school, it's best if the whole family is on board with SCD. At this age, they can also fully self-feed. So no more having to cut up or spoon feed, that sort of thing. This is a really big step for a lot of caregivers, just given that they're not as involved in the food consumption process. They're really kind of focused on their job of preparing the food, and the kids are focused on their job of eating. Another benefit to this age is low social pressure. So later on, I'm sure a lot of you have experienced kind of the older you get, the more social pressure there is. There's more social eating, that sort of thing. At this age, there's really not a lot of that. It can be challenging when they're eating something different than their classmates, but overall, they're not being made fun of. Nobody's really teasing them for having something different. Challenges, definitely pickiness. I think that really comes to the surface at this age, especially if you're introducing SCD at this age. If they've already been introduced to some of those other foods, they start to have preferences. They definitely know their favorite food by this point. They're also eating more meals outside of the home. So often at this age, they're starting school, they're starting preschool, they're kind of readying for elementary school. Oftentimes meals are either provided at school or by school, which can be a little bit of a challenge. Increased socialization as well can be a challenge. They are outside of the home with those other caregivers, with other children, and they're often playing and interacting more frequently, which can be a challenge to make sure that they're staying on track following the diet. Tips and tricks at this age, trying to make food fun. So whether that means like cutting their cheese slices into little stars or making their pancakes into a smiley face, making it entertaining and engaging for them to eat is really important. Also involving them in meal preparation. So obviously 3 is not going to be as capable as 6, but they do start to be able to be more involved with baking, cooking, helping prepare, even just washing fruits and vegetables, getting them into the kitchen, getting them engaged, helping them understand where these things come from. Also, remembering your role as the caregiver versus their role is really important. Letting them do their thing. Your job as the parent or the caregiver is to provide them healthy, SCD-compliant food. Their job is to decide of what you offered them, what they're going to eat, and how much and when. So we don't necessarily want to force feed or force them to eat the things that we're offering. Just let them decide from what you've offered. And then packing meals and snacks, I think this kind of goes across the board, but preparation in advance makes things much easier, having meals and snacks on board if you're going to be outside of the home for a long time. All right, so elementary school, more kind of getting older, becoming more aware. They are typically more in tune with their body at this point, which is really a significant benefit. But making sure that they're starting to be aware of how food impacts them, how they're feeling, because they're more in tune with their body. They're kind of becoming real people at this point. They have opinions, they know more, so helping them determine their trigger foods, understanding why they're feeling better when they're eating SCD. Able to be more involved in food preparation, getting them into the kitchen, allowing them to help. They do have still pretty increased energy needs at this point, but we've kind of decreased to more of that 50 to 65 range in terms of calories per kilo. So still eating a lot, but not quite as much as their younger counterparts. And then they're old enough to really start to understand part of their diagnosis. I think this age is particularly tricky because they do understand a good bit. So talking to them about their diagnosis, what it means to have IBD is really important. But it can also be a challenge because they have increased awareness of differences. So having something that maybe their friends don't have, having to navigate that situation can be a challenge just because they're starting to become aware of those differences. Also, if we're implementing the diet at this point, those developed preferences have become very strong. Maybe their favorite food is Cheetos, and we're probably not going to have those anymore. So it can be hard to steer them away from some of their previous favorite foods. And like I was talking about, too young to fully understand. So while they do start to kind of understand I have this difference, I have IBD, I don't really know what that fully looks like, I don't really know what that fully means, it can be a challenge because they don't understand, why do I have to eat this way? Why are my friends not dealing with this? Tips, my biggest tip to families is definitely to look for alternatives to similar products. So if they're wanting fruit roll-ups, maybe looking for like fruit strips, something like that, that will give them kind of the same feeling, the same overall experience without being exactly the same as what they were eating before. Use terms that they can understand when you're explaining. So you don't necessarily have to talk down to them, but trying not to overwhelm them with a lot of technical or medical terms. And then again, packing meals and snacks for school and activities. So at this age, they do tend to be out of the house more and doing activities outside of school. So they're not just in school, they're also maybe starting ballet or soccer practice or gymnastics. And oftentimes those things come along with parents providing snacks or meals, that sort of thing. So talking with their activity directors, talking with their coaches, whoever may be their caregiver for that period of time, and helping them to understand what their needs are. So elementary to middle school, we're kind of starting to maybe get into some of y'all's age ranges. So old enough at this age to remember those legal and illegal foods. So in this preteen phase, they're becoming increasingly independent, increasingly strong-willed, and this kind of tends to be the age that when I'm talking to parents, I start to say, we can't do this for them. Your child really has to be on board here. Prior to this, we can kind of do it for them. Oftentimes, we're able to kind of control their environment, but with this increased independence, they really have to be on board. Luckily, their energy needs kind of decline at this point. I know that sounds counterintuitive, as this is oftentimes a time from parents where I hear I'm being eaten out of house and home. What do you mean their energy needs are declining? But at this age, the differences between genders also kind of start to develop in terms of their needs. They're also typically able to identify those trigger foods. So like we were kind of touching on yesterday, sometimes even SCD compliant foods can cause issues. So maybe mango is not well tolerated just given the high fructose content. Maybe even though nuts are legal, sometimes those cause you some abdominal discomfort, and they can really start to identify those things and what their individual needs are. And they're often open to trying more new foods. So younger than this, they're not really willing to try like octopus, for example. You tell them, oh, it's really good. They're like, absolutely not. But at 13, maybe they're a little bit more willing to try some of those new foods. Challenges, if we're implementing SCD at this age, oftentimes they have really firmly established food preferences. They've eaten with their friends, they look around, they see what everyone else is having, they know what their favorites are. There's also more time away from home. They're starting to go out and do things with their friends' houses, going to the mall, wherever they're going to see a movie, and we're not there all the time to be with them and monitor exactly what they're taking in. Food frequently is provided by those activities, those friends at the movie theater, wherever they are. Kind of around that age of 13 is really when that starts to pick up and become a challenge. So talking to the kids, including them in the conversation, is a really big tip and trick that I tell my parents and families. Make sure that they really understand and feel like this is their choice as well. Trying to shift to more of a partnership mindset. So really working as a unit. So it's not just the parents dictating, you have to do this. This is what we're going to do. Get used to it. Do what I tell you to do. And let them tell you what works for them as well. I always recommend at this age speaking with school and activities about the child's dietary needs, also having a 504 plan in place for any accommodations that they may need in school or activities. Middle and high school, this is usually the most challenging time for my patients, especially implementing SCD at this age. I think this becomes the age where they understand the consequences, but they don't fully see the big picture oftentimes. It can be really, really challenging to ask a child to overhaul their whole life, their whole diet in middle and high school. This was the age when I was diagnosed, so knowing that I was different, and I didn't want to tell people. So for the first year after I was diagnosed at 14, so from 14 to 15, I told not a soul. I didn't even tell my grandparents that I had it because I was so just kind of coming to terms with it on my own. So for patients, I really talked to them about, okay, well, what is this going to look like for you? What consequences are there? How do we know what's going to work best for you? They're also able to independently prepare meals and snacks, which is huge. If you're a parent, you probably know that as soon as they can start packing their own lunch, a lot of that burden comes off of you. So they start to begin to prepare those meals, those snacks to take with them. They have more accountability and responsibility as well. They're also able to contribute to their own education, doing their own research, understanding, reading, talking to people who have similar challenges can be really helpful for them. Challenges that increase social pressure, I think middle and high school are a really difficult time for a lot of people, especially to feel different. So just understanding where they're coming from when they say, oh, I don't want to do this, I don't want to be, the odd one out can be really important. Increased appetite as well. This one is challenging. I do find, particularly with my teenagers, a lot of them like to skip breakfast, and then they'll maybe eat school lunch, but they usually come home in the afternoon absolutely ravenous. And they don't care what they eat, they just want something to eat. So having those SCD-friendly options is really important. And then hormonal changes as well. So between our boys and our girls, sometimes there can be really big differences with what's going on at this age. Typically, we're at least starting puberty, kind of going through all of those changes that can make a huge difference in their lives. Tips and tricks, providing resources for them in terms of research or connecting with people who may be going through similar issues, like you all are doing here today at the conference, and allowing them to be the primary decision maker. I think 13 to 15 is really the age when we start to see if they don't want to do it, they're not going to do it. They're out more, they're with friends, maybe they have older friends who can drive. They don't have to be on the diet if they don't want to. So allowing them to be that primary decision maker, the driver of continuing the diet or starting the diet is really important. And then speak with them about navigating social situations and developing alternative plans. I'm a big proponent of plan ahead, make sure you know what you're doing, what your plan is. If this situation arises, what do we do? Having that in place can take a lot of the pressure off of when the time comes to be in that situation. So high school. This is when I started the diet. I started the diet around 16, so I was just starting my junior year of high school when I started the diet. I found that a really big plus side for me during this time was knowing that I had decision making for myself. I could advocate for myself. During this time frame, you really start to feel like you're becoming an adult, even though from our perspective, my perspective now, I look at 16-year-olds and sometimes I'm like, oh my gosh, you're so little, and it's not true when you're in the moment. To you, it doesn't feel that way. So allowing them to advocate for themselves. At 18, they are legal adults, so they have full medical decision making. They decide if their parents are involved. They decide what their treatment looks like. Ultimately, we have to get permission from them to share any medical information with their parents if they're over the age of 18. So it can be definitely a challenge if they're not on board. But they also are able to advocate for themselves within the medical community. So not only with their GI doctor, but maybe they have multiple people on their team that really need to get on board and all be on the same page. And a lot of that responsibility starts to fall to them at this age. They're also driving and able to contribute to grocery shopping oftentimes. I really encourage my patients at this age to start taking on more responsibility, especially my patients who are planning to go off to college or move out of the house soon. I say, let's start now so that you don't get to college and feel really overwhelmed trying to do this in a new city, a new place, all by yourself. Making informed decisions about implementing and continuing SCD, they have that knowledge. They know how to do the research. Trust me, they make you do a ton of it in school these days. So making informed decisions, understanding fully what SCD is going to look like, what the benefits are, why they want to continue doing it or implementing it at this time. Challenges, they are able to drive. This is a big one. I have patients that parents are super on board, kid says they're super on board, parent leaves the room and they're like, yeah, I went to the grocery store and got Twizzlers yesterday. And I say, all right, let's talk about that. Let's talk about why that's maybe not the best idea. So that presents a huge challenge oftentimes because we're not there with them. We can't be in the car with them all the time. They have to make that decision to continue to stick to the diet. Parents are no longer in control of social situations or interactions. This also kind of ties into driving, but it's no longer my mom can drop us off if your mom can pick us up. It's we're going on our own. So being in that situation, being fully independent, they have to make the conscious choice. It's a lot of, is this important to me? What can I do to maintain this? And increased stress nearing college. Stress, especially for me personally and for a lot of my patients that I work with, plays a huge role in having flares, maintaining remission. So really trying to get ahead of that stress. I think starting early with the college process, kind of laying out your options, knowing what the benefits of each place that you're going to or potentially going to would be, is really, really helpful. Tips that I give my families: really allow them to decide. Really allow them to be the primary decision maker here because we can't ultimately control their decision. Encourage them to do their independent research. Tell them, here's some resources. Why don't you look into this? Here's someone that I know who's been really successful on the diet. And plan for that transition to college. For me, when I transitioned to college, I felt like it was really helpful to have pre-prepared and to have those options in place to know what I was looking for. And college. So transitioning out of high school, leaving home, this I found was definitely the most challenging transition for me and tends to be the most challenging transition for a lot of my patients. So they are those legal decision makers. Like I was talking about, we do have to start to implement their permission to tell parents, this is the decision they're making, this is their medical decision. It can be really, really challenging for parents at this point too, just because they feel like, you look at your child and they are becoming an adult, but it's also really difficult to look at them and say, yep, you got it, your call, totally do it by yourself. Oftentimes my patients are really self-motivated, which is really wonderful. I get a lot of patients coming to me at this age saying, I want to start SCD, I don't want to be on the medications, how do I do this? So that's a really big plus side. They're also often responsible for preparing or obtaining all of their meals and snacks, especially in college. Ultimately, they're going to either have to prepare their food or find a reliable source of SCD-compliant food. So having to make those decisions and being responsible for all of their meals can be a really big plus side if they're determined to stay on the SCD for their primary management. Challenges: limited access to kitchens. This is a really big one that my patients run into and complain to me a lot about. My biggest tip was when I transitioned to college, I had a lot of accommodations in place before I even got there. So typically when you think of college, you probably think hall-style dorms, bathrooms down the hall. I was not about to do that for myself. I just knew that that was not going to be successful for me. So I was able to get in touch with the housing people before I went to college. And I talked to them and I said, look, these are my needs. Here's a note from my doctor. At my school, they did have apartment-style dorms, so I was able to live there, have access to a kitchenette. It wasn't a full kitchen, but I had enough to work with that I was able to really make some of those meals for myself so that I wasn't so reliant on going out. I also did not have a meal plan, which I felt like was really, really helpful. It was just one less thing to worry about of, okay, how do I exhaust all of this money on my meal plan? This is something my parents are paying for. I've got to use it. So I did not have a meal plan, which is typically required of patient or students living on campus, which I just felt like was really helpful. There was really only one restaurant on campus that accommodated SCD needs. So not having that meal plan was really helpful because I could still go there and just pay with my credit card, but I didn't have to go there for every single meal every single day and eat the same thing over and over. like I was saying, limited access to those SCD legal dining options can be a real challenge, especially for me, just finding that there was only that one place. Having the ability to cook at home made it a lot easier. And then increased social eating and drinking at 21. We know drinking becomes legal. It's something that can be a real challenge for a lot of people. It was definitely a challenge to navigate. I went to an SEC school, so that was definitely a big component of socialization and just understanding where my limits are. I talk to a lot of my patients about this. Oftentimes we'll continue to follow our pediatric patients through college. We don't want to kick them out during such a pivotal time. So I'll just talk to them about, okay, let's know our limits, let's know what's legal, let's understand what the important aspects of this are. And if you find that it makes you feel worse, try not to do it. And that's way easier said than done in college. I understand that, but just knowing your limits, understanding what's important. Tips and tricks, just developing those easy, satisfying meals prior to leaving home. So I did a lot of practice of finding recipes that I could make. So I had a microwave, a blender, a crock pot, a toaster oven, and a hot plate. So I didn't have a full kitchen, like I didn't have a full oven, but I developed a lot of recipes that I knew I could make quickly in my dorm room with what I had. So I made a lot of like crock pot chicken, or even just really quickly like making scrambled eggs in the microwave. Not the best, but it works. And it was easy and it was fast and it was something that I could grab and go quickly in the morning. Also just knowing, having something stocked in the freezer that I can just kind of heat up. I was very lucky in that I lived about an hour and 45 minutes from my parents. So I could go home relatively frequently, get things from home, go to the grocery store that I wanted to go to. We only had a Kroger in my college town. Well, we had a Kroger and a Publix, but the Kroger was much closer, much more accessible. So going home and having access to like Trader Joe's, Whole Foods was huge. Planning ahead, especially for your day in college, I think this is really important. For me, I felt like I couldn't leave my dorm in the morning without knowing, okay, where's my meal going to come from? What am I going to have for lunch? Do I need to bring snacks? How long am I going to be on campus? All of those sorts of things. And this really helped me just know and not have to be stressed or worried about where my meals were coming from. Like I was saying earlier, speaking with college about accommodations, this is so, so important. I have had a couple of patients who were kind of hesitant to do this just because they were saying, oh, well, I'm really well controlled. I probably can do it like anybody else. And that's probably true. I only used my accommodations 2 or 3 times during college outside of the housing accommodation. But I also had accommodations where I could just leave class whenever I needed to. I didn't have to ask. I didn't have to raise my hand and say I have to go to the bathroom. I could just leave. I could also miss class without penalty and make up my work, which was really helpful. I thankfully never had to use that one. I was actually really good about going to class, believe it or not. And I just knew that I had those on board if I need them. So I didn't necessarily need them all the time, but knowing they were there was really, really helpful to fall back on in case I needed them. That being said, in conclusion, implementing SCD in children has a lot of unique benefits over medication management. I think there's definitely a time and place for medication, don't get me wrong. And sometimes we have to come at it from multiple angles. Sometimes we have to have the diet side of things and the medication side of things for really successful maintained remission. And I think that's totally fine. In my practice, I do have a lot of patients who do both and who require both to ensure that they have successful maintained remission. SCD is a reasonable option for management of IBD in children of all ages. Obviously, those ages come with their unique challenges and benefits and require a lot of strategies for implementation, but ultimately, it's just about the child's determination. I think especially in younger patients, the parents' determination is a really huge part of that as well. So hopefully you guys learned something and feel good about implementing SCD across all of your ages. Thank you, guys.
Thank you very much. That was amazing survey of all the age groups, and I have some questions to relate to you. But before I jump on here, I have a couple of questions myself.
Okay.
So what's your thinking about exclusive enteral nutrition, PEN, EEN combinations overlapping with SCD or ahead of SCD and then transitioning to SCD at various
Absolutely.
age groups?
I think, I personally was on a complete enteral nutrition for a little while in college. It was, I want to say about 10 weeks of enteral nutrition. I was on Kate Farms. So I did have accommodations in place for that. I personally felt like when I was on enteral nutrition, it kind of went right through me. So having those bathroom accommodations where I could just get up and go was really, really helpful. And then I did transition back to SCD. So with my patients who are going through this process, honestly, I don't have a lot of patients that are on enteral nutrition outside of the hospital. So typically we'll transition them off of that enteral or parenteral nutrition in the hospital, and then they'll start either SCD or kind of going back to their typical diet before they leave the hospital.
As you guys know, some of these enteral nutrition formulas are completely not SCD. If you look at the ingredients list, it's like every single component is pretty much way on the extreme non-legal. It's amazing that EEN in 6 weeks does put people in clinical remission, and it's used commonly in Europe, but in adults it's hardly ever used, especially in the US.
Right.
But is it a backup option, or is it an overlapping option? How does it get discussed?
It's definitely something I try to bring up to my patients just so that they have all of the information, especially in the hospital at diagnosis. I really feel like it's important to kind of lay out all of their options. To be quite honest, most of them choose not to do it. It's just not something that they feel like is sustainable for them. And oftentimes our doctors are more inclined to do what's going to work and be sustainable for them. So it can be a little bit challenging to talk them into something when it's not something that they want to do, but it is offered as an option.
And just to add to that, you guys know Seattle Children's is developing an SCD-based formula drink.
I did hear about that.
And data's been put together, and there's some early data being published. It's basically a liquid pre-made formula, but it's based on SCD, right? And so we're looking forward to seeing some publications and maybe some actual commercial product you can buy that's ready to go, and could be used for adults too. Why not? All right. Okay, so let's get some great questions here. SCD diet has a pretty high protein component, right? Do you see any increase in kidney stones for your SCD patients?
I have never seen any increase in kidney stones in my pediatric patients. It's not anything that I've ever had to contend with or help my patients through, thankfully. I have heard from a lot of my colleagues who work with adults that tends to become an issue like later in life. But with my pediatric patients, it's never been something we've run into.
You probably also don't see cavities in your pediatric patients
Not
on
most
SCD.
of the time. Not most of the time.
Side benefit. All right. What kind of solid foods have been successful for 6-month-old babies and toddlers? Successful meaning they like it and will consistently eat it. Do you give them raw or cooked veggies?
So usually what I recommend, there's a lot of different kind of ways of implementing solid foods in the little ones. Baby-led weaning has become really popular in the last several years. I don't know if any of y'all are familiar with that, but essentially just offering more of those finger foods on the front end instead of using the purees as a transition. I think either is fine. I think it really depends on the child, what they're interested in. Some babies are not super interested in the purees. Sometimes they are. I often recommend, especially with the little ones, just giving them something that's going to be larger that they can kind of gnaw on instead of something that may be a choking hazard. So I know it sounds a little counterintuitive, but rather than offering them little tiny pieces, offering them bigger pieces that they just won't be able to get down whole. So either like half of a banana or even an orange slice, something like that, that they can just gnaw on. Strips of eggs are another thing that I often recommend to my patients. So essentially just making scrambled eggs, but not scrambling them, just leaving them almost omelet-like in the pan and then cutting them into strips. Those are the biggest kind of major foods. So fruits, vegetables, eggs, even proteins, as long as they're soft, those are appropriate as well.
All right, great. If a breastfeeding mom is on SCD, will her breast milk have be more beneficial to her child than if she wasn't on SCD?
Not necessarily. I think it depends on what mom is incorporating into her diet. I think the most important with breastfeeding is ensuring that mom has a balanced diet and is not just focusing on certain food groups. So it can be challenging if mom is on SCD and she's kind of fallen into her routine of like, okay, I know these foods are safe, I feel good on these foods, but there's not a lot of diversity in her diet. That can often be a challenge in terms of the nutrient composition of her breast milk. So yes and no. I don't think it's necessarily a bad thing if mom's not on SCD, but has a good balanced kind of Mediterranean style diet.
Couple of questions on mental health. Do you find that it needs to be how is it part of the overall strategy? Do you work with psychiatrists, and how does that come together?
So in our practice, we do actually have pediatric psychologists as part of our team. So actually, when I was going through my IBD diagnosis, I did work with the interdisciplinary team. So I had my GI doctor, I had my dietitian, and then I also had a psychologist as well. I find that that's really important, and I think diet also really plays a role in maintaining good mental health as well. Just speaking from experience and with my patients, I personally find that when I'm eating well, having a balanced diet, that I feel much better mentally. Like I feel less foggy. I feel like I just have a better head on my shoulders. So I definitely think that incorporating mental health care, making sure that you have a good balanced diet is really important for the mental health side of things too.
It's a big subject too. Do you have any patients who have successfully transitioned to SCD only after being on biologics?
I do. I will say it's few and far between, and I know some of us were talking about this yesterday afternoon. It can be really challenging from a physician side of things to, in good conscience, pull your patient off of a biologic if it seems to be working. So the challenge is that oftentimes if you come off of, let's say, Remicade, for example, you fully come off of it, you transition fully over to SCD, you often can't go back to Remicade. So we've kind of eliminated that as an option. And if you weren't developing antibodies, it was working really well, physicians are typically kind of hesitant to pull off of those medications and eliminate something that we knew at least at one time was really successful. I find that it's more common to kind of space out the medications. So oftentimes if I have patients who are interested in starting some dietary management, what I'll say is, okay, just know that maybe we're going from every 4-week infusions to every 6 weeks to every 8 weeks to every 10 to 12, that sort of thing. So maybe we have much less reliance on the medication, but it's still something we keep in our back pocket. I have had a few patients come off of the biologics completely, and I think that that was much more family-driven than provider-driven. So advocating for what you think is best or what you think is going to be best for your child is ultimately kind of the driving force behind that.
So do you see the pattern being SCD is adopted before biologics even comes into this picture and kind of runs the show for as long as possible?
It really depends on the case. So if our patients have a less severe case of IBD, they're able to be diagnosed and managed without hospitalization. I find that it's a lot easier for them to start the dietary management side of things. Oftentimes, if it's a really severe case that requires hospitalization and diagnosis in the hospital, then it can be a lot more difficult to advocate for just the dietary management side of things. I have seen exclusively enteral or parenteral nutrition used in the hospital, but oftentimes that comes along with those medications. So I would say it just kind of depends on the patient and the situation.
All right, a couple more questions. Can kids with fistula do SCD regimen?
Absolutely. I've had patients with fistulas have really good success with IBD or with SCD for their management of IBD. I don't necessarily think it's a hindrance to have the fistula as long as you are well controlled and doing everything to make sure that that's improving.
All right, and finally, what can be done, if anything, during C-section birth to assist the microbiome?
So there are a few relatively new practices. Sometimes they will do what's called a vaginal transplant of microbiome material. So anything that would be naturally occurring in the vaginal canal at birth. So for the infant who is born via C-section, they'll kind of take a swab the vagina and swab the infant to transfer over some of those beneficial microbes. That's not super common at this point. I think it's becoming more and more common and they're implementing it more and more. But that's the biggest thing. Breastfeeding is also really helpful for that building up of the microbiome, the transfer of those microbes from mother to baby as well.
All right, that's a fantastic talk and great answers to all your questions. She's going to be around, of course, later today if you have more questions. Thank you, Natalie.
Thank you all. Let me know if y'all need me. I'll be around today.